The patient was followed up routinely, and at a routine follow-up following a complaint of lumbar back pain, the patient was noted to have become anemic, hypercalcemic, with collapse of his L4 and L5 vertebrae, and what was clearly evidence of progressive disease. It was clearly not an indolent progression, as when he had last been seen, he had none of these symptoms, so they'd come on really quite quickly. So it's important to consider how you would treat him. He had a 2-year remission. He went into a complete response, so it's likely that he would respond to an IMiD proteasome inhibitor combination. We have discussed about switching modes of action. So for this patient, carfilzomib, which is arguably the best-in-class proteasome inhibitor that doesn't have peripheral neurotoxicity, is a good drug because he hadn't seen it before. He'd seen Revlimid, so pomalidomide may be a better drug in combination. So the combination of carfilzomib, pomalidomide, and dexamethasone would be a combination that you'd expect to work in this setting, and you'd expect him to do well. I think the question becomes, would you do another transplant in that setting? And I think that's more difficult to answer. People normally take a disease-free period of about 1.5 years as being a threshold for when you may or may not use a transplant again. And so I think it would depend upon the physical state of the patient. One thing you would consider, as this patient has a lesion in his lumbar spine that had collapsed, is whether you might want to give radiotherapy to that site to consolidate your response there so he doesn't come back and doesn't get spinal cord compression in the future. The other thing to consider would be the use of daratumumab as an adjunct, and that I think would depend upon the level of response. If the patient responded well and went into a complete response, I think it would be very reasonable to continue the carfilzomib and pomalidomide long term, and experience would say patients will tolerate that. I guess there's a question about the dosage of carfilzomib that you would use, and I think for long-term exposure you have to go to once weekly, and for me I would use 3 weeks out of 4, then 4 out of 4. But that is usually tolerable for patients, and they can stay on that long term without significant side effects. There are a number of options that you can choose from for somebody who has had what looks like a very well used regimen up front for myeloma, which is RVD followed by a single transplant. And I think all options are open. If you've had a good long-term remission, you could do RVD and a second transplant. You could switch to a different regimen. You could go from RVD to KPD or KRD, depending if the patient had been on maintenance Revlimid or not. But those would probably be the standard options you would choose from. More recently, the combination of Revlimid plus daratumumab has been developed, which is functional, but traditionally I think you would go to something like KPD or KRD.
For any patient that we would see in the clinic that has symptomatic progression after RVD and transplant, one needs to consider also the interval of time that has elapsed since the transplant itself. Now, in this case, it's not a very long period, but if you were to see a patient who was relapsing 5 years after and that had an excellent response to induction therapy, well, you know that some of the cells that remain behind may still be sensitive to the original agents. So in that person in particular, I wouldn't think of someone like that as being quote-unquote refractory to proteasome inhibitors. Or, you know, if someone were to see this sort of on a worldwide basis, they often will re-challenge with bortezomib. Here in the United States, we think more of a second in class, so we would go for usually a carfilzomib-containing combination. But I think it's important to consider that. Now, if the patient would relapse shortly after transplant, even if it was a biochemical relapse, I think there would be a greater concern that with the current agents you did not achieve the level of response you wanted, and you may want to consider a switch in class.
When I'm selecting therapy, whether it's maintenance therapy or it's therapy at relapse, one of the main things that I look at is, and I ask the patient directly, in your past therapy, what was the drug that you tolerated the best? What was the drug that you tolerated the worst? In fact, patients are a great source for this. Many will tell me, I won't take this drug again, or I won't take that drug, or this one gave me so much diarrhea, or made me feel too tired, etc. It's very important to ask the patient how they tolerated these drugs. It's very important because we have so many others that we can select. For somebody that has more neuropathy, again, I won't use bortezomib, I'll use carfilzomib or daratumumab, pomalidomide. There's many choices. Patients often can have some GI side effects from lenalidomide, and then I'll choose something else. I do think with lenalidomide toxicity, you can still try pomalidomide. That's okay. I often will have less GI side effects from carfilzomib or the monoclonal antibody-based therapies.